talking about.
Crackles are indicative of inflammation or infection of the small bronchi, bronchioles, and alveoli, which can cause increased fluid in the lungs. They can be described as either fine or coarse.
Here's one of your coarse crackles.
Specific conditions that can cause this inflammation include pneumonia, pulmonary fibrosis, acute bronchitis, CHF, or acute respiratory distress syndrome.
Everybody hear that? That coarse crackle that just doesn't sound right. Does it? Kind of rubbing sound almost. Just sounds like a lot of excess junk almost within inside those lungs. We need to re-listen. Everybody good?
It sounds scary.
Sounds scary. How are we going to diagnose our pneumonia? So over here on the right, that's what we're gonna get our sputum culture in. I like to call it a Loogie tube. We're getting loogies out of our patient, but it's actually called a Lukens tube, Lukens, Lukens tube. So you might hear some people call it a Lukens tube. We can hook it up to the ventilator suction. We can get our patient to actually cough up a little bit and get it with inside this little tube right here. There's a lot of options that we can get our sputum culture from. We can also get some blood work as well, and they can tell us a lot of different things. So our CBC, what we'll be worried about on our CBC?
I was, which one?
High, what?
White blood cell.
White blood cell count, I like it. What about our ABGs? What can we see? I've already talked about it.
CO2.
Respiratory acidosis, so our pHs, our CO2s. pH is gonna be low, our CO2 is gonna be high. O2 level, it could actually drop as well. Electrolytes, why do I care about electrolytes?
Imbalance.
An imbalance, what kinds do you think? Potassium, it could be. Really got to do with dehydration. What electrolyte is abnormal with our dehydration? Sodium levels. So we can have hypernatremia, elevated sodium levels, to be indicative of some type of dehydration status. What about butane creatinine? Why do I care about that so much? Kidney function, but it also is an indicator of what? Dehydration again, good. Lactic acid, has anybody heard that before?
Yeah.
What's that for us?
Muscle.
Ketosis, the muscles, I like it. What else? So that lactic acid buildup is gonna be a byproduct of anaerobic cellular usage. So when they're doing any anaerobic type exercise, so that can be indicative of some type of infection. When we have elevated lactic acid, that's gonna be one of those clear indicators. And that's gonna be one of the main lab works that we can draw for something called sepsis. And we can become septic from a pneumonia type of infection. So we're gonna monitor our lactic acid pretty closely as well. And then imaging, so we're gonna cause that, can get a chest x-ray.
Little consolidation.
Okay, so this is a chest x-ray, a real good example of a chest x-ray. So when we breathe in and we breathe out and we have air into our lungs, we should have this kind of clear black side right here. We may see a little bit of white with it, but for the most part, it should be that clear black side, okay? And then, of course, we have breast tissue down here. You have your heart right here in the middle as well. But does everybody see this kind of full white side in this right upper lobe? Everybody see that? That's that consolidation, that thick purulent drainage, that thick sputum that has kind of consolidated and localized within that right upper lobe. And that's what we can classify as pneumonia. And this one's actually I hate to say a mild case, but just a small case of pneumonia. Some of these instances, some of these patients, you'll see full white lungs, whited out lungs. So you'll see consolidation throughout the entire lung field on each side. And that's when we're gonna start getting into trouble, start to see that respiratory distress. That's when you're gonna start to see those patients come to the ICU, those critical care type settings. Or they should come to those settings. Our goals of therapy or our goals of treatment, our number one priority is gonna be improvement of that gas exchange. So improvement of our respiratory status. So how can we improve our respiratory status? What do y'all think? Incentive spirometer, that's always a good answer, right? Cough and deep breathe, right? That's always a good answer. What about some O2? Does our patient need O2? Sometimes, depends on what our O2 set is, right? Or what our PO2 on our ABG looks like. So we can give them some supplemental oxygen as needed, until they get back, kind of back to baseline. What'd you say? Fowler's position. High Fowler, low Fowler's, that's tolerated? Okay, so high Fowler's position is probably pretty good. Their positioning, so they don't need to be slumped down in the bed. We need to pull them up as much as possible, get their sheets nice and fresh. Take pride in your work, pull them all the way up, set them up nice and high to encourage that gas exchange. Can we prescribe steroids to them? Or we can't prescribe, but could we potentially get an order for steroids?
Depending on their underlying condition.
So steroids can help with our inflammation, right? Amber, you remember us talking about that the other day? We did. So our COPD patients, they're gonna be on a lot of steroids because they have chronic inflammation within their lung spaces, in their lung fields. Similar to pneumonia, we have a lot of inflammation within our lung fields. So we can maybe get an order for some steroids, or we'll see an order for some steroids. What about bronchodilators? Will that make sense for us?
Absolutely, yes.
Y'all remember that from the asthma lecture? Oxygenation lecture? What's a good bronchodilator? Sam, what you got?
I have a question.
What's up?
So someone is wondering.
Someone is wondering? Bella is wondering? Meredith's wondering?
I
Somebody's
would say a
wondering?
name, but it's hard to say, of course. So, if your patient is a diabetic and you prescribe steroids to make their blood sugar go, so would you still prescribe that or not?
So what are we more worried about? Are we more worried about their diabetes or that they can't breathe? They can't breathe, right?
So this goes back to MBC's airways breathing.
So airway, breathing, and circulation. I can give them enough insulin to make their blood sugar lower, right? So that's why I'm more concerned about trying to open up that airway. I'm more worried about their airway, because they're gonna die from not getting enough oxygen, enough airway. Are they gonna die from diabetes initially?
I mean, they can, but you know.
I mean, they're not gonna,
No,
they're
not
not-
immediate.
it's not immediate, it's not emergent, right? Okay, that makes sense? Okay. What's a good bronchodilator? Albuterol, inhaler, good. What do you say? Albuterol, good. So if you want to go back and reflect on your bronchodilators, you can go to get your short-acting beta agonists and your long-acting beta agonists. You can go to page, ooh, that's a 4 or 9, I think it's a 4. Page 545, table 24.1. It's gonna be classified under your asthma section, but it's gonna have a section that talks about common bronchodilators, common medications for that. So that's just a good review for your bronchodilators. Prevention of obstruction. So they have these thick, big old secretions that kind of get clogged everything up. So we're at a high risk for obstruction, right? So how do we prevent that? Good suction, good. A little Yonker suctioning to the wall. Scopolamine, we could. What else? Fluids, good. We encourage to drink fluids as tolerated. If they have CHF or some other underlying condition, just as tolerated. But fluids is great. We're trying to thin out those secretions as best we can to get them to cough those up, to cough them out, while we can get them to suction. So if they're deep down on the inside, then we can't suction them out very well.
Breathing treatment.
Sorry?
Breathing treatment.
Breathing treatment's good. So that kind of goes back to those bronchodilators. Yes, Sam?
This is Sam's question.
This is Sam's question. This isn't Meryl's question this one?
Yeah, so remember, I forgot what, I think it was maybe for cystic fibrosis, the little vibrating thing.
Vibrating thing? Okay, what's that?
Could they put this on the
Little
vest?
chest physiotherapy?
Yes, could they do this or no?
I like that,
You gotta
yeah.
cup your hand.
So
Cupping.
the chest vest itself, it's a good treatment plan for cystic fibrosis, but it can be used for a broad range of things. Or if you're old school and don't have a chest physiotherapy vest, you do what Bella says, cup your hands and just kind of beat on the back of your patient. Beat their chest, beat on the posterior side as well. I've also seen where respiratory therapy gets a bag valve mask, you know what I'm talking about, the ambu bags? And they actually get the mask itself, the little triangle mask that you put on the face. And they can actually use that, and they'll use that for cupping to do some physiotherapy with the chest as well. So there's a lot of great options that we can do. Please tell everybody else that you are doing chest physiotherapy because your EKG rhythm is gonna look lethal when you're beating on somebody's chest, just FYI. I've scared a lot of residents doing that. It's pretty funny, but let everybody know that you're doing chest physiotherapy. Prevention of sepsis. So there's a big septic workup, big septic protocol that they will initiate if there's any type of signs and symptoms of sepsis. We're not gonna get into big detail for this lecture on prevention of sepsis, but we're gonna encourage that antibiotic therapy, encourage them to take their antibiotics for the full course of treatment. We're gonna encourage those fluids. We're also gonna continuously monitor their vital signs, so if there's any changes at all, we can let somebody know so we can go to a higher escalation of care. The physician knows and kind of make that decision from there. Our ultimate goal for our pneumonia patients is to kind of get back to that normal baseline, to able to perform those activities of daily living independently. They're not getting short-winded. They are able to walk to the mailbox without getting so short of breath, going into like a respiratory distress type of situation. They're able to brush their teeth appropriately, get dressed. What do I need to educate my patient on? So the potential risk factors that could associate with pneumonia and some type of prevention strategies. So we named a couple of causes of pneumonia, for instance, the influenza, COVID-19, respiratory type illnesses. One of those most prevalent in the fall, winter, when it gets a lot colder outside. So maybe we need to do some education strategies about when and where they can go outside. Maybe they need to avoid large crowds because there's a whole lot of bacteria that can get exchanged in these large crowds. Vaccines. So they do have a pneumonia vaccine that is pretty new to the market. I did some study on it myself in my master's program, but it just got approved recently. So there's some new education. We can educate them. 65 and older is really where we're gonna educate our patients on the vaccination for pneumonia. And some immunocompromised patients, we may go a little bit earlier with the vaccinations. But you can also educate your vaccinations as far as your influenza vaccine, your flu vaccine, get your yearly vaccinations of that. COVID-19 vaccine, there's a whole lot of dilemma with that. We're not gonna go into that tonight, but that could be another vaccine that we could potentially educate our patients on. Maintenance of our hydration status. Again, encourage those fluids as tolerated. You're gonna get tired of me saying that, but as tolerated. If our symptoms progress or they're persistent, we need to tell them to seek some type of medical attention. They don't need to be at home, barely able to get a breath of air in and say, oh, I can tough it out, I'll see what happens tomorrow. Earlier intervention, the better. We don't wanna get to that emergent point where they're coming in, they're not breathing, and then their heart stops and they're in the ER. We don't need to get to that point. They're already septic. They're almost too far gone at that point. So, if we're not seeing any kind of relief of our symptoms, we need to let somebody know. or if they get worse. So those signs and symptoms, the shortness of breath, increase sputum production. If they are in any kind of respiratory distress, they see some cyanosis within their lips, and their fingers and toes. Maybe they feel like their heart is beating 100 times a minute or 200 times a minute. Maybe they feel like they're progressively getting worse and worse with their fever. Lots of options out there. And then that continuation of treatment after they get discharged. So these patients may be on antibiotics long term. We need to educate them to, again, that full course of treatment, take their antibiotics. If they are unable to maintain that consistent taking of their medications, maybe they need to go to a rehab facility or like a SNF type unit, like a skilled nursing facility, some kind of outpatient facility that can manage their medications, but can also assist them getting back to baseline with their ADLs. They can do physical therapy, occupational therapy, those type measures to hopefully get them back to baseline as possible while still kind of recovering from that pneumonia. Like I said, our goal is to get our patients back to baseline as much as possible while improving their overall airway status. That gas exchange that we're talking about. Let's move on to tuberculosis. Highly contagious infection process that's going to be caused by that Mycobacterium tuberculosis. I said that the first try. What type of precautions do we need to be on for tuberculosis? Y'all remember that? Isolation precautions, but what kind? Close, so airborne precautions, good. With airborne precautions, what type of, I guess headgear or mask are we gonna use? N95 mask, so the big green bulky mask. Drew, you're gonna have to shave if you get these type of patients. You're gonna have to wear that N95 mask, okay? What about the room has to be special? Negative pressure rooms, alright? So those negative pressure rooms, it actually sucks the air out and doesn't allow it to circulate throughout the rest of the hospital. It goes through these specialty HEPA filters and will actually take out some of that bacteria, and that way it doesn't get recirculated and potential exposure to those other patients. You need to keep those doors nice and closed. A lot of them have some type of little ball or some type of light kind of above the doorway frame, so you know that it has a good adequate seal around the doorway frame. That we know that it's a negative pressure room.
Does 6 or 7 happen?
Do they?
They do. They're in the corner units, so 6104, 60.
105.
5.
And then 6101.
And then 29.
And then 36.
Okay, there you go.
And they're in the same place on each floor. What East Alabama does not have, but some may traditionally have, is what they call an ante-room, and if I'm jumping ahead.
No, go ahead.
Is a ante-room, so you notice for the 6th floor, for example, outside of those negative pressure rooms, that's where that little mini sink and paper towels are. That's their version of an ante-room. But most of them, the nurse will step inside of the ante-room, change into the hazmat suit or whatever the equipment is for that hospital, scrub in, and then go in the room. And then same thing, they strip before they go back into the ante-room, wash out, and then go back into the regular. We need to go see an ante-room. So we're meeting tomorrow or Thursday. We're going.
Really kind of like you see on TV, on like Grey's Anatomy and those, they actually show a good job of those where they're going into it's a separate little section, a little area right before they go into that main patient contact room. So they can get fully prepared, fully suited up to go in and come take care of them. Yes, sir.
So how often do you see a patient?
I have never taken care of one with tuberculosis.
Same.
So fun fact.
But
you do not
they do
have it.
exist, there are other negative pressure room things I have seen patients placed for, but not tuberculosis.
In the ER, you'll get a chest X-ray and like we'll say on the reading,
Round glass.
indicative for the hospital.
Yes, Sam.
So I don't have it, and I'm not expecting y'all, but ever since I was a baby, I've always tested positive for herpes, so I always have to get a chest X-ray.
Cool.
Every time.
We'll talk about it in a second, actually, so.
But I'm not contagious.
For tuberculosis, our most prevalent areas are gonna be those underdeveloped type countries. The ones that are more poverty stricken, that don't have good quality access to healthcare. They're not, able to have the kind of that hygiene standard. That's gonna be our, kind of our most prevalent area. So, our most concern is when patients travel overseas, or they're in the kind of underdeveloped type countries. We're also worried about our immunocompromised type patients. We're also worried about our patients that are in these like group type settings, group type homes. So sometimes, like for instance, like a nursing home or like a halfway house, like a mid-house. Jail, it could be a good instance of some ones that are in kind of close quarters that are at high risk for tuberculosis. So that's kind of our high prevalent areas. United States, we really have seen just kind of a steady decline over the years. So tuberculosis is, I hate to say rare, but it's pretty uncommon that you're gonna see it. Like I said, I've never taken care of a tuberculosis patient before, but
Knock on wood.
knock on wood, yes. Our signs and symptoms are really going to determine what kind of stage our tuberculosis is in, and that's how we classify our TB. We have what's called acquired immunity, or like a dormant phase of tuberculosis. So we're initially infected with the bacterial infection. We may or may not show symptoms. It may just be a little bit of like a sniffle, maybe just kind of a sore throat, may have a little bit of sputum production, a little bit of nasal type drainage. But we think it's just a cold and things kind of go away. They lay dormant. They're kind of just not really there, don't really exist. And we don't really think anything about it. But what that bacteria does, it kind of lays up in those alveoli, like I said, dormant, and kind of grows and kind of just kind of sits there and kind of hangs out. With our latent TB, that's going to be kind of our next step from there. Our latent TB, it could present itself weeks to years later after the initial infection of tuberculosis. And that's when those bacteria within those alveoli, they've hung out for a while, and then they said, all right, I'm ready to go. And then they'll kind of take over the host defenses. And that's when we're gonna start seeing those signs and symptoms and have that real progressive, full type infection. After that, we can have that symptomatic management. We can treat tuberculosis best we can. And then we can have what's called a secondary TB, or kind of a reactivation of that primary type infection. So what are we gonna look for with our TB? We're gonna have some chest tightness, just overall not really feeling well, can't get that good breath of air. It's very similar to a pneumonia type feeling. Just not able to expand those lungs as we should. We're gonna have a little bit of fatigue, weakness. Maybe a decrease in your level of consciousness, have some fever. We can also have a little bit of blood within our sputum. So again, based on the phase is gonna be what our signs and symptoms present as. Here's a good chest x-ray for TB infection. There's actually better ones than this, but we just kind of have scattered areas consolidation throughout. And it's really wherever those bacteria decide to settle in within our lung fields and within our lung spaces. And when they start to produce and replicate more, then we get that consolidation. So we're gonna have just kind of scattered consolidation throughout. Chest x-ray is one good diagnostic tool, but we have blood testing as well. We also have the TB skin test that we're gonna talk about in a minute. And so we have some of those other tests as well. Together, that's how we can confirm that diagnosis of TB. We're also going to get a sputum culture as well, and we can actually single out that bacteria and confirm that tuberculosis infection. I'll put this slide in here. It shows you the infection and how it kind of replicates within the alveoli, I wouldn't spend a whole lot of time on this slide if I were you. All right, what type of test is this? TB skin test. You know the other name for it? Will. It develops a will. It starts with M, right? The Mantox. I like it. Mantox test. MANTOUX. With our TB skin test, we're gonna get the initial injection, and it's a little protein that's within that liquid that they injecting you, and it has a little bit of that allergen in there, and they're gonna see if we develop a reaction from it. What we're looking for with our TB skin test is the area of induration. That's what we're most worried about. Yes, we can have some erythema, some redness around the site as well. But that could be just from an injection site type of reaction. That's not what we're most concerned about. We're most concerned about the little area, the little wheel of swelling, the induration. That's what we're most worried about. For a normal, healthy individual, greater than 10 millimeters of induration, we can consider them either exposed to TB in the past, or they may have a dormant phase of TB, or that acquired TB. It doesn't necessarily guarantee that they have TB currently and it's an active TB that they could spread the tuberculosis infection with. At some point in their life, they might have been exposed to tuberculosis. That's when we would do a little bit of further testing, the chest x-rays, the blood type testings, the sputum cultures, things like that. Anybody that's at high risk, that's immunocompromised, that has come from a high-risk area. So for instance, if they traveled overseas, or if they're in a group home, they're in jail, we could be considered at high risk if we've been exposed to TB within the work setting. Your HIV type patients, they're immunocompromised as well. 5 millimeters or greater is gonna be our cutoff for them. So anything greater than 5 millimeters, we need to do some further workup to ensure that they are not active and infected. Does that make sense to everybody? Okay. After the initial injection, gonna do 48 to 72 hours afterward, and then you're gonna get a reading from that. And I'm sure we've all gotten TB skin tests, correct?
Yes.
Kind of the gold standard for blood testing these days is gonna be the quantiferon gold, is what you're gonna call it. They'll pretty much drain your whole entire body of blood. They get a lot of blood from, it's 4 or 5 different type tubes, and they can actually test to see if you have active TB at that current moment. So. This is just kind of a precursor to the next slide, and what we really need to consider when we're talking about tuberculosis treatment-wise for our patients. It's a very extensive process to treat our patients with this. And that's what we need to educate our patients on. It's gonna be a long, drawn-out process. It's gonna take a long time to fully eradicate this infection, to get it come back in that dormant phase, to get rid of your active symptoms. And you have to be really compliant with your medication regimen, and you're gonna be on a lot of medications.
Does it ever really go?
It stays more like a dormant phase, and you can kind of have almost like relapses of the active infection. So I copied this directly out of the book because a lot to type. It's on a big table. So this is directly from your book. Table 25.4. It's on page 588. This is kind of our first line treatment for tuberculosis. It's 4 main medications. And so we have your isoniazid. I'm terrible at saying these. So rifampin, your pyrazinamide, and then your ethambutol. That's the big 4 we're going to talk about. What do I need to know about this slide? I wouldn't worry a ton, but we need to understand what these medications will do. They are all liver toxic. It's gonna be a big player within our liver. So it causes some big liver toxicity issues. What are some signs and symptoms of liver toxicity? What do I have to watch out for? Kaylee had a great patient the other day for signs and symptoms of liver toxicity. You had a liver cancer patient, so what did he look like?
He's very honest.
Very jaundiced, so yellowed skin, right? What about his eyes? Was his eyes real yellow? Okay. Do you remember why you, about his urine? You remember you asked me why is it so, what?
Red, dark.
Dark red, yellowy, remember that from his Pubic? Alright, that's kind of excess bile getting excreted with output of urine. So we can have some dark colored urine, that's another sign and symptom of liver toxicity. And that's what we need to know about our big four here, is it causes a lot of liver issues. Specifically with rifampin, we need to educate our patients, which is just kind of ironic, is that it can cause reddish orange secretions in general. So how can we distinguish that from liver toxicity versus the rifampin use? We can draw some lab work and stuff to confirm if it's our liver versus just rifampin. But they're gonna cry like an orangish red. They're gonna urinate an orangish type red. So it's kind of interesting. With all of these as well, we need to encourage an increase in fluid intake because it can hurt the kidneys as well. It can also increase our uric acid level as well and cause gout. So liver toxicity, know your signs and symptoms for that. Increased fluid intake for all of these. All of these are also going to affect contraceptives as well, so use a backup form of contraception. And that's about what I need to know from this slide. Questions about that? Put it in here, it's a good read, it's things you need to know, but I wouldn't stress too hard about this for the test. Questions about tuberculosis? Anna, you got a question and you just raised your hand?
No, I'm just-
Okay, cool.
Waiting.
Let's move on to our urinary tract infections. When we're thinking about a UTI or a urinary tract infection, we really think about kind of the urethra as the setting for our UTI, but it can really affect the entire urinary tract itself. Anywhere from the kidneys down to the ureters within the bladder, down into the urethra. It can be kind of a mix of all of them or just one of them. And that's how we're gonna classify what type of UTI that we have. As far as classification goes, we're gonna have an acute or a chronic type. Acute is more gonna be just at a sudden onset. We have one every once in a while. That's gonna be that acute urinary tract infection. As far as chronic goes, we're gonna have 2 or more in 6 months or 3 within a year. So we have these recurrent, you get a little bit better, and then you have another one. Get a little bit better, have another UTI. As far as your types go, your uncomplicated UTI is gonna be just your bladder involvement. So you're gonna have some cystitis, so inflammation within the bladder. As far as a complicated UTI, it's gonna be more than the bladder. So it can be bladder involvement with your urethra. It can be bladder involvement with your ureters and your kidneys. As far as males go, you're really gonna see them get lumped into the complicated section because it's very uncommon for males to develop a urinary tract infection. Just based on our anatomy, our urethra is a lot longer than females, and so we're less prone to urinary tract infection. So if we do get one, they're gonna kinda lump us into this complicated type. can cause a UTI?
Lemonade. Too much sugar.
So too much sugar, so that's for diabetes mellitus, right? Why does too much sugar matter?
Changes the pH.
Changes pH. Our bacteria love sugar, right? They gotta have something to feed on, right? So we have an excess of sugar, they can feed off of that. And we can have an overgrowth of bacteria within our urinary tract. Our diabetes mellitus patients, they're going to excrete that excess sugar through their urine. So we can develop an UTI from that. An obstruction, why does that matter?
Because if it's not flowing, it's just stagnant and it's just creating that.
Good, if it's not flowing, it's just stagnant and it causes bacteria. So our urine is just kinda at a standstill at this point. We're not flushing out that excess bacteria, getting that new bacteria in, and we just kinda have that overgrowth again of bacteria. We already talked about male versus female, age plays a role in it as well, and it kinda can go in both ways. So the younger population, so the children, especially with females, really need to encourage them to wipe front to back. And so we could see a high instance of UTIs with females as they kind of start to get a little more independent and they kind of go through that potty training. Anybody know what a vesicular urinary reflux is?
Is that when they have a perforated colon and it goes into the?
It is not.
No, but I know.
Zach, what you got?
It's when the urine goes back up the ureter as they're urinating or voiding.
Good, perfect. And so with your ureters, we have a backflow of urine back up into the kidneys because the valve between the ureter and the bladder is not working effectively. And so that backflow of urine is also causing the urine to stay within your urinary tract for a longer period of time to again have that overgrowth of bacteria. Sexual activity, there's a lot that goes around in sexual activity. So there's a high chance that bacteria can get introduced within the urinary tract. And then use of antibiotics as well. And it can cause to kill off some of that good bacteria while allowing for some of that overgrowth of that bad bacteria to occur. On the reverse side, we have our signs and symptoms. We have the top three right there, that's why I kind of highlighted them in red. Patients are going to talk about frequency. They're urinating more and more frequently throughout the night, throughout the day. Urgency, they always feel like they're about to urinate themselves. They're about to have an accident of some sort. And then dysuria, so they're having complaints of paining with urination. We can have some others as well, hematuria, that's when you're gonna have a real complicated, more serious type urinary tract infections. We're gonna have some blood in our urine. We can have some instances of retention as well. The big ones y'all think about is cloudy type urine, so just kind of the kind of nasty looking type urine. I put LOC on there as well. A lot of times you will see the older population, especially in the females, when they have a UTI, they have some type of change in their level of consciousness. They're not oriented to themselves. Data is mixed on that. From my personal experience, I have seen some changes in their LOC, their level of consciousness with it.
Fistula, that's what
Oh, okay.
I was, because one of the clients or patients had.
Signs and symptoms wise, our causes for our UTIs. If you look at page 416, there's a table, 58.4, that's a good one to look at. I would probably know my signs and symptoms of a UTI. Box 58.8 as well, 58.8 on page 1418, sorry, 1418. That's gonna be your symptoms.
Well, I have hysterectomy. Prolapse.
If we're talking about UTIs, we're gonna talk about catheter-associated urinary tract infections.
Goes with, yeah, they both right.
The urinary tract gets infected due to an insertion of either a in and out catheter, an indwelling catheter, or something of that nature, something that is draining out their urine. That's where we get our infection from. Why does that occur? It could be from a list of different things. Was there some type of improper insertion? Did we break sterility when we inserted our Foley? Bella says she's gonna break sterility. What she was saying. She was nodding her head saying yes. Maybe we have left the indwelling catheter in too long. Maybe our patient didn't need an indwelling catheter at all. So these are some things that we have to consider when inserting a urinary catheter. That education prevention section, that's a good one to look at. That could be some questions that we could ask you for your Foley checkoff as well. What does my patient even need it for? Do they need it for urinary retention? Are they a post-operative patient? Are they in surgery and they need it? Maybe we need very accurate intake and output. Or we're trying to promote skin protection. They have some kind of skin breakdown that could get irritated from incontinence. We're gonna daily assess for the continued need of the urinary catheter. The shorter amount of time that we can leave the indwelling catheter in them, the better. It's less chance of introducing some type of bacteria into the urinary tract. Is there other alternatives to that urinary catheter? So what could be some other options? That was a question.
What is?
Other options for urinary catheter? A PureWick.
There we go.
Good, so you can have a male or female PureWick, right? What about a condom cath? I like a condom cath. The old school condom caths work really well. Brief, we could put that on them. If they don't have any skin breakdown, that could be a good option for us. We don't want any kind of break within our system. Once we place that Foley, I'm not changing the bag out frequently. There's a little section where it connects. I'm not pulling that off from the main urinary catheter to the back. I'm not leaving the bag on the floor. That can be a reason to introduce bacteria into the system. And then I can also assess that urine volume. And so, I got you set. That urinary volume. So we can do one of those pelvic ultrasounds, that bladder scan ultrasound. We're able to do that. Josh did one not too long ago. So. And see how much urine is in that bladder. Are we going to try to encourage them to void on their own and kind of hold off and wait and see if they can void on their own before we insert that indwelling catheter? Yes, sir.
So if they have to have this for like months, don't you have to change it ever so often, like the whole thing?
Depends on hospital policy at that point. I believe EAMC is 30 days. Which is a long period of time. You're really gonna see that in more of your nursing home, long-term care. If you have like a paraplegic, quadriplegic type situation, some of your neuro patients, your ICU, critical care settings. During COVID, they had them in for a long period of time. So, just kind of depends on the specifics of your facility. How are we gonna diagnose these patients? How are we going to know that they have a UTI? Well, really, it's gonna be, what now? Your analysis, good. Our first steps are gonna be mostly off symptom presentation. So they come in complaining of that dysuria. They come in complaining of urgency, of frequency. Can't sit. So some of those type symptoms. And then we can get that urinalysis and further break it down. And so we're gonna have some positive leukocytes, so we're gonna have an increase in white blood cells. We're also gonna have some positive nitrates as well. When we have an overgrowth of bacteria within our urinary tract, they're gonna produce these nitrates, and so we're gonna have a positive nitrate within our urinalysis. We're also gonna have sometimes if it's a infection that lasts a while, have that increase in white blood cells. We can further go a step, and your physician may order a urine culture with sensitivity. Instead of just throwing broad spectrum antibiotics at them, we can now actually narrow down what the bacteria that's causing this infection and what it's susceptible to. What type of antibiotic will kill off this type of an infection? Initially, they may go on some of that broad spectrum stuff. Once the urine culture comes back, that physician may change some things up, so you'll see that. So what are we gonna do to treat? Antibiotics, yes. Non-surgical wise, we're going to do fluid intake. So again, increase their fluids. We're trying to get to like 1.5 liters-ish a day, 7 to 12 voids. That's kind of our goal. That's a lot of water for the typical person. Unless you're Josh, who brings his jug every day. This is thirsty.
That's a great way to release water weight, Josh, don't show.
But about 1.5 liters, 7 to 12 voids. That's what we're trying to shoot for. Pain type management. Azo, that's a good one. That's that benzopyridine right down at the bottom, that analgesics. But what are some things that we could do that's not a pill? Heating pad, we could do that, good. What about a sitz bath?
Yeah.
Warm sitz bath.
It's not good for the bathroom. Sitting in there.
I mean, we're not sitting in there for long periods of time. We're getting warm water, we're sitting in there for 10, 20 minutes, and that can kind of alleviate some of those symptoms. If it's real painful for them to urinate, we can encourage them to urinate within the bath, get out, and then clean up from there. That bath can actually help them urinate.
I don't know.
It's
what
kinda gross and
this is
disgusting.
called, but- So after you have a baby, they give you some stuff to put down there to, help, do they do that for this?
No,
You don't talk about, what do you mean? It's like, it's not witch hazel, it might be witch hazel.
That's for
Hemorrhoids.
hemorrhoids.
I'm talking, it's some stuff they put on the vagina.
I think it's wish hazel, I think.
I don't do women's health, so I'm not 100% sure what you're talking about. Okay, look it up and let me know.
No, you're talking about a douche?
Yes.
No, it's like, no.
We call it dermoplast.
Yeah, you,
Dermoplast?
dermoplast.
And the numbing spray?
See, I knew I was
A
talking.
numbing type spray. There you go. I learned something new every day as well. So.
Say, ask the professional on that.
We're also gonna get on some antibiotic type therapy. So these are kind of your big main four that you're gonna see. So you have your nitrofurantoin or your macrobid. Don't get confused with like a heart type medication because it just says nitro in there. I've seen that mixed up before.
What? Seriously?
Yeah, this isn't nitroglycerin, it's an antibiotic.
No, I mean, but people mix that up.
Sometimes, yeah, it just has nitro in it, that's the first thing they read and they go for it. So.
Okay.
We're gonna just call it Bactrim, that's what we're gonna, trizoprim, sulfamethoxazole as well. It's a combination therapy, but it's called Bactrim for short. Phosphomycin, ciprofloxacin as well.
Cipro's the big one.
Cipro's a real good one for your urinary tract type infections. And then, as Amber mentioned, Azo. These are some analgesics as well. Your benzopyridines. What's important with our benzopyridine? What's it gonna do?
It's gonna turn everything orange, so try to make sure you don't wear anything white. Because if you do tend to pee yourself, you have orange all over you.
Okay.
Yes, sure.
Yes.
Guys
So,
are close.
it's going to turn your urine orange.
No, he told me that when I first used it.
And it'll really freak people out if you're in the bathroom and you start peeing orange and they look over. You're peeing orange. They really think you're sick.
Why are people looking over?
It's a male bathroom. It happens. Anyway, especially if it's like a trough situation and not like true. You wouldn't know. Anyway.
So out of these medications, which one is the most important to test or all?
I would not worry about this a lot. Hold on.
Appreciate you so much.
You wouldn't worry about this a lot?
I would worry about it, but I wouldn't worry about it.
the two main ones that get
Cipro
picked
Facts.
up.
He's losing us.
Do not worry about it.
Cipro, Bactrim, your Macrovid, that's gonna be your biggies for, treatment wise. Again, analgesics, difensopyridine, there is some mixed data on your methylene blue as well. It's not really a scene with your UTIs, for your analgesic type pains, for your, urinary type pains.
If they use your kids.
Methylene blue,
Yeah.
I can use for a lot of common things. If they do get it prescribed, educate your patients on your urine will be blue instead. So now they're peeing orange and blue.
Amber's like, I want mine to be blue. After the blue cupcakes in mine.
Alright, our big thing for patient education.
Continue to drink a lot of water and.
This is a great slide for us to look at. Continue to drink adequate fluids, like Amber said. Okay? Our education is really based on prevention and symptomatic management, the reoccurrence of symptoms. We're gonna drink plenty of fluids, only if there's some other pre-existing condition that will not allow us. So again, that's CHF type stuff. Frequently empty your bladder. We're not gonna hold our urine for long periods of time. So one of the highest prevalences of UTIs is within female nurses, or nurses in general, because we hold our urine for a long, long period of time. We may go 12 hours without going to the bathroom. Not great for management of UTIs. We're really trying to not have that overgrowth of bacteria. So we're frequently flushing our system, allowing for minimal bacteria as possible. As far as females, patient education wise, we're trying to avoid irritating substances, we're trying to avoid bubble baths at all costs, any kind of constrictive clothing. The use of douches is not usually indicated for that as well. And then as far as males go, really just adequate hygiene at this point. And as far as both females and males, we need to talk about sexual intercourse health. So you need to avoid after sex, that's a big one, avoiding after sex. Nurse is caring for a client who has a Foley catheter following gynecologic surgery. Which action by the assistive personnel requires nursing intervention? D. Placing the collection bag on the floor to prevent kinks in the tubing. Okay? Emptying the collection bag in a container. I don't really care about that, that's fine. Washing hands prior to emptying the Foley. Again, that's fine, we're okay with that. Flushing the urine in the toilet after emptying the collection bag. Doesn't really matter to us, it doesn't really do a whole lot. So D, that's a great answer. Josh ran into this the other week as well. He had a big kink in his Foley catheter bag that was actually causing a backflow of urine. So once he got rid of that kink, he had like 400, 500 cc's of urine come out at once. But we need to figure out a way to get that kink out without just laying it on the floor. So there's a lot of options. Sometimes these urinary catheter, the bags, they get rotated a bunch, and so they're kind of corkscrewed up, and it doesn't allow them to lay nice and flat and straight, causes a kink within the tubing. So if we rotate it the opposite way and kind of get that rotation out of it, it'll not cause that kink in there anymore. Straighten it out as much as possible. I've also hanged it from the bedside trash can right there. Make sure it's a clean trash can, but just kind of hang it off the side so it's nice and straight to kind of prevent those kinks. Josh taped it to the bed, which is a great idea. So lots of options. Another question, which of the following factors increases the risk of developing a urinary tract infection?
C.
Holding in urine for long periods of time. Drinking plenty of water, that's great. We're trying to flush out that bacteria as much as possible. Wiping from front to back, especially in females. We don't want to introduce any of that E. coli type bacteria within our urinary tract. And then urinating after sex, That's definitely a great one as well. Trying to flush out any bacteria that got introduced into the urinary tract, during that sexual intercourse. Alright, osteomyelitis. Somebody had one of these the other day. Meredith had osteomyelitis patient the other day.
You have a hell of a memory.
Pay attention, guys. Do I? I don't pay
Except
attention to
for
dialects, I don't care about that.
I paint is called.
I think. So osteomyelitis, let's talk about it. It's an infection that occurs within that bone tissue, deep down into that bone tissue, and can even involve some of that bone marrow. And that's where our infection is going to occur. Have a lot of inflammation, a lot of swelling, a lot of edema, some erythema around the site. A lot of severe type pain, chronic type pain. It's really hard to control their pain. This slide is going to show us our process of infection. So initially, we're going to have some type of pathogen invasion, and that's how we're going to classify our osteomyelitis, and we'll look at that in another slide here shortly. But somehow, the pathogen has invaded into our bone tissue, into our bone marrow. Once that occurs, some of that inflammation is going to occur, some of that edema is going to occur. With all that excess fluid and that swelling within that site, that's actually going to cause a breakdown of our blood vessels to occur. Once that occurs, we don't have any type of blood circulation within our bone, and we can actually have a part of that bone kind of break off, have that necrosis of that bone. So we can kind of develop that abscess from that, and once we have that abscess, that's how we get that really nice nasty infection. So top left, work our way around to the right, work our way down and around. That's how this chart reads. Some good examples, some good looking pictures here. Picture A is once that bone is kind of broken off, it has necrosed after that loss of that blood circulation to that part of the bone, and it's kind of broken off and has developed that bone abscess. And so that's how we can see it in picture A. Picture B, we've kind of opened it up already. We kind of see that they've kind of debrided this site already. So we have some nice pink healthy tissue at this point. We don't see any necrotic tissue. We don't see any purulent discharge, kind of a yellowish green look to it, which would be like a sign and symptom of some type of bone infection.
I have to have gone for a very long time.
Yes.
Before they got medical.
Are these people okay?
What now?
Are these people who are stuff that you
I have seen some types of infections, but these are, some of these are for Google. I think one or two of these might be from the book as well. So, my best one for osteomyelitis was a big sacral wound, that occurred, and they did some debridement. And, he had a lot of junk in the trunk, and so I was able to actually touch his sacral bone, and when I put it in, I could put my fist, both fists in all the way up to like almost my elbow. So, and that's for how much treatment they had to do to kind of take care of that infection. And he had a lot of bleeders as well, and so I had to sit there and keep him packed for a while the surgeon came back in to cauterize some of the bleeders. But
So you kept your arm in there?
pretty much kept my arm in his butt for about an hour or two until the surgeon got there.
How did
Cause,
that feel?
you just sit there watching TV, so it's like 2 o'clock in the morning.
So
And
awkward.
he's intubated and sedated. I mean, you know,
Oh, so he didn't know nothing else was wrong.
It'd be kind of awkward to have a conversation.
it is. It can be some type of awkward conversation. How do we classify our osteomyelitis? How do we break down our osteomyelitis? This is a really great slide as well. So we got really 3 main types, and then we can classify those as an acute or chronic type infection. First and foremost, we have our exogenous type infection of osteomyelitis. Somehow an infectious organism was introduced within the body from the outside world. So some type of trauma, some type of open fracture, maybe some type of puncture wound, something like that. And then we further break it down, we go to endogenous. So we have infections somewhere else within the body, such as maybe UTI or bacteremia that can occur. So an infection within the bloodstream. And once that infection occurs, it travels through the bloodstream to that site of infection, to that bone marrow within that bone site, and causes that osteomyelitis. So that endogenous is also called hematogenous as well. So hemat, bloodstream type infection. Then we also have contiguous type osteomyelitis. And this is going to be from the surrounding tissue, so it didn't have to travel very far. A great example of this is some kind of diabetic type foot wound that had got infected, and then it kind of got within the bone around that surrounding tissue. Or maybe our patient had real bad, poor dental health. They had some kind of infected tooth, and that has progressed into an infected jawbone. And then acute versus chronic is going to be on this next slide right here. This is a very great slide as well. Page 1040, box 42.2 is going to kind of list your signs and symptoms of your acute versus your chronic type infection. As far as your acute infection, you're going to really break it down into the pain. It's constant, it's localized. When they move it, it gets progressively worse. Just kind of this sharp, pulsating type pain. You're going to see some redness, you're going to see some erythema, you're going to see some swelling around the site. Really kind of like this bottom left picture right here. Could be a touch of cellulitis in there as well, some infection around some of the skin around the site. Versus your chronic side. Typically, your chronic side is going to be from some type of orthopedic type surgery, like some kind of sacral wound debridement, where they had to get a part of that out. Maybe they had tib fib repair or had a femur repair, and they weren't very clean within surgery, and so they developed some type of infection from that. I have a lot of excess drainage from this. A lot of just purulent drainage from that bone abscess. That's a great example on the right over there of a jaw type infection. Jaw osteomyelitis there. That mandible bone getting infected. How are we going to treat osteomyelitis? Osteomyelitis is a pretty big deal. It's a pretty long, extensive recovery process, a long, extensive type treatment. So initially, we're going to start them on 6 weeks of IV therapy of antibiotics, and we're going to use the big boy antibiotics at this point. We're going to use something like vancomycin or daptomycin. So those are real broad spectrum, progressively strong type antibiotics. We don't want just to further to progress. Complications can be that MRSA though, so that methicillin resistant Staph aureus. We can have some vancomycin resistant type stuff as well. That's going to further complicate our treatment options. The 6 weeks of initial IV therapy, and then we're going to follow with 48 weeks of oral therapy. And so, are we really going to require our patients to be in the hospital for 16 weeks? Maybe. But we can also treat this in an outpatient type setting. So they could go to wound care, get their dressings changed. Maybe they could prescribe them some antibiotics. Some patients can go home on IV antibiotic therapy and then they can progress to oral antibiotic therapy. But if they're not able to, then that's when we're gonna send them to more of a SNF type unit, a skilled nursing facility, or some kind of outpatient type clinic, where they can also get that physical therapy, that occupational therapy, and they can also get their medication management under control. Our big thing for surgical wise, we're basically gonna cut out the bone that's infected. We're gonna try to debride as much area around the site, trying to get those clean margins where there's no source or sign of infection. That can be really hard to control and really hard to estimate how extensive that infection has gotten. And of course, the pain management. So we're gonna use some of the big narcotics, some of the big benzos. This is another option, I just included this, just kinda to general know, not super important. But if we're sending our patients home on IV antibiotic therapy, we can get something like this. So it's called like a bulb antibiotic, bulb infusion, balloon infusion. It's pretty cool stuff. They'll go home on a PICC line, so a peripherally inserted central catheter, a PICC line. More of just a long-term indwelling type IV instead of just one of those peripheral IVs that may not be as secure. These PICC lines are a whole lot more secure, and patients can live with these, go on about their daily lives for months at a time with those. As far as this goes, we can connect the end of the IV infusion, kind of like we do in the hospital setting with our IV pumps. So we'll connect it directly to the PICC line. We'll educate our patients on how to flush it, make sure it's in the right spot, aspirate, make sure we get good blood return, and then we can fully flush it, make sure it's nice and patent. And then we educate our patients on how to properly kind of screw on the cap of this balloon infusion to our PICC line. And once they unclamp it, the pressure within the balloon itself actually infuses it into the patient. So they don't have to an IV pump or anything like that. They can carry this around in their pocket. A lot of times they'll get a fanny pack or something like that, or a backpack of some sort, some kind of bag to carry around. They'll carry around their purse. And then they can go on about their daily lives. They can go to work, they can go on vacation, they can travel and still get their antibiotic infusions as they need to. Usually somebody on diabetic foot wounds, not going on a lot of vacations, but just in theory. Pretty cool stuff. Again, I have a bullet point at the end, and it's kind of repetitive in nature, so it's kind of important. Our goal is to get our patients back to baseline, and that's really important for pretty much all our patients. Getting them back to baseline as much as possible, and able to return to work, able to do those activities of daily living, whatever that may be. We're also gonna provide some type of mental health support for them as well. They have this big, nasty, gnarly infection. They may have an excess amount of bone that has been cut out. It's gonna be a big mental health type situation, visualization. How do other people see me when I have this type of infection, where I lost a lot of bone? And so how do others see me or present me as? We're gonna educate them on that medication management again to complete the full course load of your antibiotic therapy. Signs and symptoms of infection if it progressively gets worse. So what's some signs and symptoms of infection?
Smell,
Smell, drainage,
heat,
heat, pain, good. We can also talk to them about physical therapy, occupational therapy, how to dress the wound, how to care for the wound after surgery. Questions about that? That's all I got as far as the infection lecture goes. A few more things here. Something new I found. See if it works like it's supposed to.
Oh, no.
All right. Haley. Some patient education that I need to know about pneumonia. Yeah, just give me a couple of things. What do I need to educate my patient about pneumonia? Or their treatment plan or anything? All right, so stay away from large crowds. That's a good one. What else?
Get your flu shot, COVID shot.
Get your flu shot, COVID shot. One more.
Incentive spirometer.
Incentive spirometer. Why does that matter?
To help get the lungs working like they should, like promote.
Promote what? A gas exchange?
Yeah.
Fully expand those lungs like we should? All right. I like this purge situation.
No, it's absolutely worthless.
All right, so again,
Oh, Lord.
Oh, yay.
of course, Sam, all right. Yeah.
Oh, you know, it's okay, because I can see the whole thing about this walking to. So, for bacterial bilateral BD, stick pregnant discharge. For the viral, it's unilateral, it's gonna be watery and stringy. For the allergy, it's gonna be watery on and off symptoms. There you go.
That sound correct, everybody?
Yeah.
I would, y'all better not say no.
What happens if we do? What?
Then I'm gonna tell you that,
You're wrong.
we were wrong. I wouldn't lead y'all.
More. Kamaya loves to speak.
So does, I can't be responsible.
Patient education for urinary tract infections.
To PF, urinary sexual intercourse.
PF for sexual intercourse, I like it. What else?
Don't hold urine during long periods of time.
Don't hold urine, okay. Is that enough patient education? That sounds good. Drink plenty of fluids, that's plenty enough, okay. We'll do a few more. and then we'll-
Cleanliness is a big
Don't put it on you.
I'd like to at least talk about each one of these disease processes, so we'll see.
UTI again.
UTI, treatment plans this time, all right, Anna?
You got antibiotic therapy, you have fluid therapy, you have prevention. and-
Name prevention.
A prevention for a
For UTI.
UTI. Avoid UCAS,
UCAS,
urinary catheter.
urinary catheters, okay, good.
Hmm?
Avoid sex.
Avoid, just
sex.
avoid sex.
Okay. Comment on that? All right.
No.
Signs and symptoms of osteomyelitis, careful. It's the last one we talked about, should be the most fresh.
I believe she went to the bathroom.
Yeah, I actually did go to the
Oh,
bathroom
you
this
did
one.
that, awesome, honestly.
I did for real, and it took me a long time to get there.
Can we
Oh,
figure out?
Sure, let's phone a friend on that.
Phone a friend.
Fever,
Fever.
swelling,
Fever, swelling, severe pain.
tenderness.
That worsens with movement.
Worsens with movement, so that's our what, acute type osteomyelitis.
Pulsating pain.
All right, what about chronic side?
Of drainage at the site.
Drainage at the
localized
site,
pain.
localized pain, good. That good enough for us?
Yes.
Okay, let's go again.
Oh my God.
Oh, we haven't talked about tuberculosis yet, okay.
Tuberculosis.
Tuberculosis, signs and symptoms. What you got, Sam?
If they're gonna have really coughing, they have some blood in their sputum.
Okay, I like it.
They may have difficulty breathing, they may have fever, they may have change of consciousness, is that in that one?
It can be.
Can be. There's, the biggest one is gonna be how like their chest X-ray looks and, the alveoli.
And the alveoli,
Yeah.
good. So we can have some consolidation throughout our chest X-ray, depending on where the bacteria end up settling in our alveoli. That good for everybody? All right, let's remove tuberculosis, and we'll keep going. Well, causes of a urinary tract infection.
Hold your page long.
okay?
Not being sixth, tight clothes.
Right, close.
Like clothing, alright.
What?
Bubble bath.
Bubble baths, good.
Lemonade.
Alright, maybe the ice.
Oh, Dr. Chuck.
Osteoarthritis causes
Dentation, ordentation.
ordentation, alright.
Surgery.
Surgery,
Trauma.
trauma's a good one. What happened to, Caroline, alright, that could be a good one. Open fracture.
Yeah,
She didn't have an open fracture.
I had air
Oh, Bella again, alright. No, I took, pneumonia causes. What now? We did not.
We did do
No, we did causes of pneumonia.
Did we?
We did. Sure.
We did treatments and everything.
We did treatments in pneumonia,
That's
alright.
what Haley did.
Alright, pneumonia causes, Bella. Surgery.
No.
I mean,
No,
maybe.
viruses?
Viruses, what type of viruses? Flu, COVID, some type of respiratory type infection, right? Okay. Maybe we'll get Bella again, let's see. Oh, Josh's time. Causes of influenza. We didn't really talk about causes of influenza. Give me some signs and symptoms of influenza.
So, fever, dehydration, cough,
Okay.
just body aches, chills,
Chills, okay. What could it progress to? We just talked about pneumonia, good.
or death.
We're dead. Hopefully not dead.
I mean, you look,
Are we in the 1800s?
People die from flu.
Drew,
Oh.
we talked about causes of conjunctivitis, but let's repeat it. Good repetition.
Yeah, just, not cleaning your eyes out,
Okay.
bacteria.
What's one of the specific viral causes that I talked about?
COVID.
Chlamydial? Chlamydial infection? What are we concerned about with that? Sexual abuse?
Yes.
Children? What about that third type? We have the viral and the bacterial conjunctivitis. The third type is really gonna be a good cause.
Allergic. yeah.
Allergic. So what's some things we could be allergic to?
Yes.
Dogs, cats, pollen. My truck is pretty much known with its pollen. Pepper spray, yeah, maybe it causes a lot of redness.
It's an irritant.
what? What about pepper spray?
Alrighty. Last one for this.
Meats.
Okay, give us some big patient education topics for otitis media.
We're gonna educate about not getting your ear wet, keeping it dry.
Okay, Russ.
Yeah, if it's infected, then you're gonna lay on that side and not drain it.
Okay,
You're
good.
gonna eat like soft foods.
Why eat soft foods?
Just give it your jaw muscle.
Good. Perfect. Alright, one last thing, it'll be a kind of review for our upcoming tests. And then we'll get out of here. Good.
Is everything
What now? Yes. Y'all wanna take 5 minutes, come back, we'll get started? Everybody ready? Alright, we're taking 5 minutes.